All right. Looks like we have a good participation today evening. Thank you, everyone, for joining in. And today's Grand Rounds is going to be again centered around a very important theme of infiltrative cardiomyopathy, particularly amyloid cardiomyopathies. And Dr. Sabat Bukhari is going to present the talk today. Before we go there, I'm going to just share the screen to get you with the information that is necessary for getting if you're able to see my screen. Again, we have all the Grand Rounds on the YouTube website. For the CME credit for this session, the text code is 20375 to the number 888-816-4893 as an SMS message. So you can take a second now, settle down and do the text message. And for the physician's MOC credits, we have the room code future 49, and the link will be available in the Zoom chat box. And this link is also available for 12 hours after the event. So you can go and take the quiz and get your MOC credits. So once again, text 20375 to 888-816-4893 and take the MOC credit for a physician's ABIM website. If you have a cloud CME profile, you get a direct MOC credit with the code future 49 if you answer the questions at the end of the completion of this event. All right, with that, we come to introducing Dr. Bukhari once more. It's always a great pleasure to bring him in. And I want to spend a minute thanking him for really developing a very important center for the New Jersey State, the Amyloid Center. It's just about under a year, and the center has seen tremendous growth. I do not have the exact board numbers, but I think it's in closing somewhere around 400. Imagine our nearby university affiliates have about 600 or 700 patients that they follow up, but our center has grown just under 1 year time, thanks to the work. But it also showcases that this disease is underrepresented in our clinical diagnosis, and I think there's more work to be done for early recognition and referral. I would also like to highlight Dr. Bukhari has taken over the multimodality imaging program, and now he's able to also provide answers to some of the difficult imaging that we may have, particularly while encountering this disease, and differentiating it from other types of thick heart conditions is an important goal of all this educational programs that have been developed by him. Joining him today on the panel, I would like to also introduce two important people. Number one, I'm really pleased to welcome Dr. Jakpreet Grewal as our panelist. Jakpreet joins in after his heart failure fellowship from Medical University of South Carolina. And he is going to assist Dr. Bukhari with managing some of these complex cases. Believe it or not, many of our patients are coming from outside the state. There have been some international visits as well. And many of the patients walk in with milrinone IV lines and very difficult to manage medications on board. And many times, heart failure cardiologist having in the vicinity is going to be a really added bonus. So Jakpreet is going to join there. We are looking into Thursday afternoon to supplement the care of our patients. But in addition, he's also going to help Dr. Bukhari work on the hypertrophic cardiomyopathy and in general, the cardiomyopathy clinic that we are trying to develop. And his focus also would be to develop a niche in pulmonary hypertension, because all of these diseases come together with pulmonary hypertension, and differentiating the different reasons for pulmonary hypertension is a common situation that is encountered. So I think Jakpreet will focus on that, and he's going to join today as our panelist. So welcome, Jakpreet. So we look forward to your contribution to the division. And when Jakpreet is going to be busy on the service, we will have Dr. Kenneth Dalnawan. So our panelist again for today is Dr. Dalnawan. And Dr. Dalnawan, believe it or not, has been taking some interest in hypertrophic cardiomyopathy clinics, and many of the patients have been previously following with him. And now, of course, there's a concentrated effort between the heart failure teams and Dr. Bukhari to manage some of these patients. So this is again coming to fruition of a journey which has just begun. And with that, I will have Dr. Bukhari come over and give his presentation, and which will be followed by the Q&A sessions. Thank you very much, Dr. Bukhari.
Thank you so much, Dr. Sengupta. So let me see, share screen. Can you see the slides?
Yes.
All right, I'll just jump in. So the objective for the talk is to have an overview of cardiac amyloidosis and to discuss what should prompt suspicion for this disease and how this suspicion can be confirmed through diagnostic techniques. And then discuss the non-invasive diagnostic imaging modality, which is nuclear imaging with PYP scans. And then lastly, just have an overview of treatment options for ATTR cardiac amyloidosis. So this journey started in 1854 when Rudolf Virchow, he's considered the father of pathology, in 1854 coined the term amyloidosis. That's derived from two Greek words, amylon, which is starch, and eidos is resemblance. So when he looked at under the microscope with iodine staining, he thought these were the starch resembling molecules there, and he named it as amyloidosis. Then Andrade in 1952 from Portugal and their group first described the clinical presentation of amyloidosis as a form of peripheral neuropathy in a case report. And then Rukavina from US reported two family series of 29 cases and reported the same thing with familial amyloid polyneuropathy in these patients. And then Fredrickson from Germany and their group first described the cardiac involvement in 1962 with amyloidosis. So there are about 35 different types of amyloidosis. And out of those, 9 involve the heart. The two most common ones which involve the heart are immunoglobulin light chain amyloidosis, which is called AL, or transthyretin amyloidosis, which is ATTR. So about 95% of all the cardiac amyloidoses are by these two amyloidoses. The other 7, which are serum amyloid A, which is usually in chronic inflammatory disease, rheumatoid arthritis, chronic infections, inflammatory bowel disease, or apolipoprotein A1 or apolipoprotein A4, and then those other rare ones. So AL amyloidosis is basically produced by bone marrow plasma cells, which produce immunoglobulins and overproduce these light chains, and then these light chains misfolds and form amyloid fibers. AL amyloidosis is considered a medical emergency. It typically presents in patients who are 50 years or older, and the median survival from diagnosis of untreated AL cardiac amyloidosis patients is less than 6 months. So it can be differentiated from other type of amyloidosis by different testing methods. So it is really important to rule out AL amyloidosis as soon as you suspect that the patient has amyloidosis. So the other amyloidosis which is common has cardiac involvement is transthyretin amyloidosis. So for the purpose of this talk, will be focused mostly on transthyretin amyloidosis. So transthyretin is a transporter protein for thyroxine and retinol, hence the name transthyretin. It's produced mostly by liver, but also by choroid plexus and also retina. But most of the production is by the liver, and it's in the form of a tetramer. It's stable in the form of a tetramer. When it dissociates and forms monomers, those monomers then misfold and form amyloid fibers. These amyloid fibers are then deposited in the interstitium between the cardiac myocytes, and then they cause dysfunction of the heart muscle. There are two subtypes of ATTR, and one is called wild type, which in the old days we used to call senile type, and the other one is called a variant type, which in the past we used to call mutant or familial. The most common one is the wild type ATTR cardiomyopathy. The one which is the hereditary type, the three most common mutations which are present in US are V122I is the most common in US, and then V30MET mutation is the most common mutation worldwide, and then that is divided into early onset and late onset. And the third most common in US is called ALA60 mutation. There are a total of about 130 mutations which cause amyloidosis. The most common ones, like I said, V122I, which about 3.5 African Americans carry that mutation. So that means there are about 1.5 million carriers of this disease in the US. But the penetrance is not well known. It's a couple of studies that have shown that the penetrance is anywhere from 37 to 40% for this V122I. As compared to other mutations, which is ALA60 mutation, which is T60A mutation, that's called Irish mutation. 1% of patients who are from Donegal County in northwest of Ireland carry that mutation. And that has over 90% penetrance. Now, if we come down to the third most common, which is V30MET mutation, V30M mutation, the late onset involves the heart, and the early onset involves the nerves, causes peripheral neuropathy and autonomic neuropathy. And the early onset usually starts in late 20s and early 30s in patients who live in Portugal and Japan. But the same mutation starts at a later age in their mid-50s, the ones who live in Sweden. And the late onset V30MET mutation causes mostly cardiomyopathy and less peripheral neuropathy. So ATTR cardiomyopathy is underdiagnosed, and it's misdiagnosed in about 34 to 57% patients. And about 75% of misdiagnosed patients have received treatment for the misdiagnosed condition. And the most commonly, which I see in the clinic, are some of these patients have been diagnosed with hypertrophic cardiomyopathy and have been put on Camzyos, and I've taken out a few patients off of that. And some of these patients who have been diagnosed with the amyloidosis have hypertrophic cardiomyopathy. So this disease gets a lot of misdiagnosis. And in a survey of patients with ATTR-CM, 17% of all responders reporting visiting 5 different physicians before receiving the correct diagnosis. And these are the ones who were diagnosed. So when we look at the autopsy data on people who are over 80 years of age, 25% of those hearts have TTR cardiac amyloidosis. And among older patients with HFpEF autopsy, 17% had TTR in their heart. Now, from diagnosis, if the patients are untreated, V122I mutation patients, their average life is 2.6 years. And the other mutations vary from 2.6 to 5.8 years, but the most common mutation in US is V122I. So untreated, these patients' average life is 2.6 years. And untreated for wild type is from 3.6 to 4.8 years. So if we look at the incidence of the disease, AL amyloidosis, only 10 per 1 million patients, and there are about 3,300 cases per year. Total cases in US are about 20,000, and about 50% of these have cardiac involvement. So this is a rare disease, AL amyloidosis. Now, ATTR variant type, like we said, 3.5% African Americans are carriers. So this is not so rare. ATTR wild type is not rare. So now we're going to go over what should raise your clinical suspicion for this disease. You look at clinical presentation, biomarkers, ECG, echo, and cardiac MRI. So clinical presentation. So this disease has heterogeneous presentation. It involves multiple systems. And that's one of the reasons that this disease is misdiagnosed or underdiagnosed. And whenever you are looking for this disease, you have to act like a detective and put your internist hat and think about this disease because it involves multiple systems. So starting with cardiovascular, like we said, HFpEF, 13% to 17% patients who have HFpEF have wild type ATTR cardiomyopathy. Other thing which is very common, your patients who are hypertensive or who have heart failure, and they become intolerant to these medications for hypertension or heart failure medications, think about amyloidosis. The other is low voltage relative to LV wall thickness. So discordance between the voltage and the LV wall thickness. And then echo showing increased LV wall thickness. Cardiac arrhythmias. About 70% patients of ATTR cardiomyopathy have atrial fibrillation. There are other patients who have conduction abnormalities. And these patients who have atrial fibrillation, so you do not have to look at CHAS-VAS score for these patients. You treat all these patients with anticoagulant. And even the patients who are on anticoagulant, they still have clots. So you do not schedule the patient for cardioversion who has amyloidosis unless or until you do TE first before doing cardioversion, even if they have been on anticoagulant for a long period of time. So important to do TE prior to that. Then aortic stenosis, patients going for TAVR, 22% of the male have ATTR wild type. So important to think about that in patients with aortic stenosis. Then we look at nervous system, peripheral neuropathy, small fiber. They present with that first, including tingling, numbness, burning in their feet, fingers, And then it extends into large fiber, which causes weakness, weight loss, and then become really debilitated and are wheelchair bound or bedridden. And also it causes autonomic neuropathy. Most of these patients complain of postural symptoms, postural lightheadedness, and also GI symptoms, which could be because of the mucosal involvement of the GI or due to the autonomic nervous system involvement with bloating, chronic diarrhea, weight loss, sexual impotence. And then the other thing for ocular is they get vitreous opacities and glaucoma. And if we look at the musculoskeletal and orthopedic symptoms, these precede anywhere from 6 to 15 years prior to cardiac involvement. So very important that if you have patients with bilateral carpal tunnel syndrome, who have bicipital tendon rupture, lumbar spinal stenosis, or hip or knee arthroplasty, think about this disease in these patients. And then renal impairment and cardiorenal syndrome. So if we look at TTR cardiac amyloidosis, so bicipital tendon rupture and lumbar spinal stenosis are characteristics for ATTR. And for AL, you'll have periorbital bruises, you'll have macroglossia and submandibular lymph node enlargement. Those are characteristics for AL. So we looked at about 150 patients with aortic stenosis. And what we saw was that 22% of the males and about 3% of the females who were going for TAVR had TTR cardiac amyloidosis. So, and altogether it was 16% of these patients. So imagine how many patients we sent for TAVR who have some LVH, and how often do we check for amyloidosis. Over here, probably, I haven't seen anyone screening for this. So then what we did was we came up that, criteria on which patients you should look for amyloidosis who are going for TAVR. So patients who are over 65 who have severe AS, who have a wall thickness of greater than 14 millimeter and do not have hypertension. And then if they have one major criteria or two minor criteria, in those patients you should screen for amyloidosis. And those major criteria are mostly musculoskeletal or chronically elevated troponin or NT-proBNP. And the minor criteria are diastolic dysfunction of grade 2 or greater, AFib, or any AV blocks. Then we look for biomarkers. So cardiac biomarkers that may raise suspicion for ATTR-CM include chronically elevated troponin levels, low grade, which we see lots of patients who keep on coming back to the ER, and if you look back, they have chronically elevated troponin. And then or NT-proBNP level elevation. If you have those two and have LVH, think about amyloidosis in those patients. Pre-albumin and looking for albumin to calculate your modified BMI and eGFR, these are helpful for looking at the progression of disease or response to treatment. Remember, before we do anything for TTR, we always need to rule out AL amyloidosis. If you think about amyloidosis, your first step should be to rule out AL amyloidosis by looking at free light chain ratios and doing serum and urine immunofixation to rule out for monoclonal proteins. As we said, that this is a medical emergency. If untreated, their average life is less than 6 months. So there is now Mayo Clinic staging system for TTR, UK staging system, and now we also have Columbia staging system. So Columbia, the only thing is they have added troponin, NT-proBNP, eGFR, and also added the dose of diuretics. And those help us stage the disease and look for the prognosis for these patients. ECG. Now, there are certain ECG features should raise suspicion for cardiac amyloidosis. In particular, discordance between LV wall thickness and QRS voltage, or pseudo-infarct pattern, which is in the inferior wall and anterior wall, which is present in up to 70% of cases, or conduction disease, AV blocks, which is present in up to 22% of the cases. Atrial fibrillation is present in 70% of TTR amyloidosis patients. Now, prevalence of low QRS voltage varies. In ATTR-CM patients, only 20% have low voltage, and 30% of ATTR-CM patients have LVH on their EKG. So if you see LVH or if you do not see low voltage, that does not mean the patient does not have ATTR cardiac amyloidosis. In AL amyloidosis, about 60% of the patients have low voltage. Echocardiogram. So we look at the echo. When you see the images clearly, if you look at most of the textbooks of echo, the image on the first page on the cover is usually an amyloid patient because it looks beautiful. Then their walls are thick, especially the LV and RV. Cavity size is normal. Atria are enlarged. Interatrial septum thickness and your valve thickness is greater than 5 millimeter. They have pericardial effusion, and they have the sparkling appearance on them. And if you look at the left lower image, this is patient in sinus rhythm. You can see that left atrial appendage thrombus. 33% of the patients with amyloidosis have a thrombus in left atrial appendage, whether they're in sinus rhythm or in AFib. So this, you have to be careful in these patients and have a lower threshold than putting them on anticoagulation. And then what we do is we look for diastolic dysfunction, grade 2 or greater. And we basically say if there's a triple 5 sign, that means your mitral S prime, E prime, and A prime are less than 5 centimeters per second. And then the last one we look at is longitudinal, global longitudinal strain, in which there's apical sparing. And when you look at the polar map, it gives you that cherry on top appearance. But this can also be seen in patients with aortic stenosis, patients with hypertrophic cardiomyopathy. So this is not characteristic for just for amyloidosis. So things which are important when we are looking at the echo are these clues which you should when you have an echo report or you're doing an echo, if you have these clues, think about amyloidosis. If there is an unexplained LV wall thickness of greater than 12 millimeter, plus if you have grade 2 or worse diastolic dysfunction, or reduced Doppler S prime, E prime, and A prime wave velocities of less than 5 centimeters per second, decrease longitudinal strain of less than 15%, minus 15%. And then there's another criteria which is there, which goes by a score system. And so if the relative wall thickness is greater than 0.6 LV wall thickness, that gives you 3 points. And then Doppler E prime wave velocity of greater than 11 gives you 1 point. TAPSE of 19 gives you 2 points. And longitudinal strain of less than 13 gives you 1 point. And then systolic longitudinal strain apex to base ratio greater than 2.9 gives you 3 points. If the total score is greater than 8 points, then there's a high suspicion of cardiac amyloidosis in these patients. Other thing which recently a lot of places have started looking at is looking at the septal reflectivity ratio. And if that ratio is greater than 1.5, then a couple of the studies which just came out have shown that that can differentiate ATTR cardiac amyloidosis from AL or other conditions. So summary of echo findings: increased LV wall thickness, thickening of the AV valves and interatrial septum, speckled appearance, normal or near normal LV fraction, ejection fraction, diastolic dysfunction, pericardial effusion, and apical sparing pattern, and then SAB and septal refractivity ratio. Cardiac MRI. Again, there are clues on cardiac MRI which raise suspicion for cardiac amyloidosis. If we look at the top row of images, if we look at the first, which is vertical long axis, you can see the LV wall thickness, atria that are enlarged. When you look at the horizontal long axis, then we can see some pericardial effusion. In the middle image, pleural effusion, thickened walls, normal cavity size for the LV and RV, large R and LA, and thickened interatrial septum. Same things what we went over on the echo on the cine views. Same thing on short axis thickened. But when we look at the late gadolinium enhancement, you can see that the blood pool over here is dark. It's a dark blood pool. And then this, which you are seeing white area, this is all subendocardial enhancement. And myocardium is also nulled in these patients. So you're going to see the same thing on horizontal long axis. You'll see the involvement of the LV and the RV and the atria. And then you see the subendocardial enhancement in the LV side and RV side with nulled myocardium in the middle, which is called the zebra sign on this. And the same thing you see on the short axis. The other thing which we look at in amyloidosis is T1 maps. So if you look at the T1 map, this is the healthy volunteer hypertrophic cardiomyopathy and AL and TTR amyloidosis. You can see that the red is elevated T1 map. So you can see these red dots in AL, which is a high T1 map value. Same thing with TTR, but AL is usually higher than the TTR. And there's really not that much in healthy volunteer, and HCM is normal. And then the other thing which we look at is extracellular volume, which is also raised in these patients. And ECV is very important in also looking for the progression of the disease. So once you're treating the disease, you want to see if they're responding to treatment or not. Following ECV really helps in those patients. So now we come down to how non-invasively we can diagnose these patients. So echo, MRI, EKG, clinical symptoms would suggest that the patient might have amyloidosis, but they are not diagnostic. So if you look at the nuclear imaging modalities, they're bone-seeking tracers. So I'm going to just, for the sake of time, just stick with bone-seeking tracers, which are PYP, pyrophosphate, HMDP, DPD, and those three tracers are the SPECT tracers. With pyrophosphate is used in US, South America, China, Asia, Middle East, and DPD is used in Europe, and HMDP is used in France, mostly. Then if we look at the MIBG imaging, which is sympathetic innervation, that's usually used for familial amyloid polyneuropathy patients, younger, that means V30 MET mutations, patients who are usually negative with PYP imaging. Then I'm not going to go into the other imaging modalities right now. So this really all started by Pulier and group from Germany, who first reported in 2002 a case series of 8 patients who had familial amyloid polyneuropathy. And they looked at DPD scan on these patients and found out that 3 patients who had arrhythmias or heart failure symptoms, their heart lit up with DPD. So they basically concluded that this might be a useful test with DPD to look at heart involvement in amyloidosis. And then Perugini and group from Italy in 2005, they presented that 15 of their TTR cardiac amyloidosis patients, out of which 10 were variant type, which is familial type, and 5 were wild type. And then 10 AL patients and 10 controls. They looked at those patients and did a 5-minute scan, whole body scan, and then they did a 3-hour whole body scan and looked for retention of DPD in these patients and looked at the heart to whole body retention ratio. And they found out the patients who had a ratio of greater than 7.5, that was 100% sensitive and 100% specific in diagnosing TTR cardiac amyloidosis. And then the same group, Rapizzi's and the Perugini group, looked at the prognostic data on these patients. And in 2011, they published that if you look at the LV wall thickness and looked at the heart to whole body retention ratio greater than 7.5, these patients did worse as compared to the ones who had LV wall thickness of less than 12 millimeter, or their heart to whole body retention was less than 7.5. So based on this, I wrote to FDA and asked them if we could use DPD in US. And they basically told me, no, you cannot because it's not approved in US. So then I looked at the DPD structure and saw that PYP was closest to it. PYP was readily available in US and was approved already for blood pool imaging, for MAGA scans, for GI bleed. Also in late 70s, we used to use PYP to diagnose myocardial infarction. At that time, we did not have CPKs or troponins, so that's how we used to diagnose myocardial infarction, by giving them PYP. And also PYP is used for bone imaging. So based on that, I wanted to develop a protocol which would be a simple protocol, because if we do a whole body scan in US, because most of the cameras in US are in the cardiologist offices, so whole body scan, you need a different camera which is in the hospital and has to be read by nuclear medicine physicians. We wanted to come up with simple protocol which would be low-cost study, standard dosing, should not be based on weight. So I designed this study in which it would be based on total counts, so that we don't have to worry about calculating the dose for each patient. It can be performed in outpatient setting, shorter imaging protocol, less radiation, easy image interpretation, and does not require nuclear medicine physician for interpretation. So the top one is the whole body imaging, which was done by DPD scan, and the bottom one is the PYP scan or imaging, which we developed. So that if you look at the top one, it takes about close to 3.5, 4 hours, and the patient has to lie under the camera, has to get the whole body scan. So what we did was we just did the chest image, so the cardiologist can read it, and do a planar scan in 1 hour. And if there is some uptake, then add the SPECT. And if you see clear-cut myocardial uptake and no blood pool, you're done. So done in about 65 or 70 minutes. And if you see blood pool, then you do a 3-hour imaging with SPECT. And we wanted to come up with an easy way to diagnose this. So we did a visual assessment in which you look at the myocardial uptake, then compare it to the rib uptake. So if there is absent cardiac uptake, score is 0. 1 is mild uptake, less than ribs, and 2 is equal to ribs, 3 is greater than ribs. If the score was 2 or greater, then it was positive for the TTR amyloidosis. Then what we noticed was there was a lot of inter-observer and intra-observer variability between the score of 1 and 2. So we decided to come up with a quantitative score in which it would be not too much subjective. So that we just draw ROI on the heart and then mirror image copy it on the contralateral side, get the mean counts. And if the ratio was greater than 1.5, that was 97% sensitive and 100% specific in diagnosing ATTR cardiac amyloidosis. There was one outlier on our study, which was a rare mutation, and those mutations are always negative with PYP imaging. So then the other thing which is important with PYP is always to get a SPECT scan, because that helps to differentiate blood pool from the myocardial uptake. So these are, which we already discussed. If you look at the middle image, this is at 1 hour. You see some blood pool, it clears up at 3 hours. So it's always good if you see blood pool, you repeat the image in 3 hours. You can also do your visual scores on your SPECT images if you do not require planar images. Now, just to show you, if you do not have a SPECT CT scanner, then you cannot rely just on SPECT images, because if you look at this patient, is a 68-year-old female patient, past medical history of coronary artery disease and HFpEF. If we look at it, score is grade 2, and heart to contralateral ratio is 1.36 at 3 hours. That means it's positive for amyloid by that. And if you look at just the left side scan, if you look at this left image on the lower left image, it almost looks like this is all LV uptake with apical sparing. But this, if you put it with the SPECT CT and look at it, you can see the myocardium. There's no uptake. It's all in the blood pool. So you can get burnt if you do not have a SPECT CT and rely completely on SPECT scan. Other thing which is important to know is that DPD, HMDP, PYP all work, but not MDP. Somehow MDP, there is no myocardial uptake in MDP. So when there was a shortage of PYP a couple of years ago, and a lot of people started using HMDP or MDP. And that time we realized that MDP, there was no myocardial uptake. So MDP is not a good bone-seeking tracer for diagnosing TTR cardiac amyloidosis. Other thing which is important to know is that there are certain mutations, especially the type B fibril amyloid disease, does not light up with PYP scans. So if you have patients or they have a history, family history in which they have 59 lysine, 64 leucine mutation or some other mutations, in those patients do not rely on PYP scan. Even if the PYP scan is negative, you either do a genetic test or do the endomyocardial biopsy on these patients. This is one of the examples for 78 patient in which PYP was completely negative, and when we did the PET, it was positive study. Now, people have moved forward, have started looking into quantifying this, especially with the newer SPECT CT cameras. You're able to get SUVs for these patients. So people are looking at SUV max, SUV mean, cardiac amyloid activity, percent injected dose, and then retention index, SUV peak. All these things, multiple papers have come out in the last 5 years, but really nothing has shown that it would stick. So it has been always an issue. Then just going to skip that. The reason for false positive TTR for PYP scan is AL cardiac amyloidosis. 10% of AL patients have grade 2 or 3 on PYP scan, and also blood pool. So these are again quantitative. I'm just going to skip these. So then what we did was we got all the data from our site in 2013 and also from Mayo Clinic and BU together, and looked at prognostic significance of PYP scan, and that was at 3-hour imaging. So if the 3-hour imaging where the cutoff is 1.3 or greater is positive at 3 hours, if your heart to contralateral ratio was greater than 1.6, these patients did worse. Then what we did was we had 9 amyloid centers from 5 different countries. 4 were from US and 5 from outside. We got all our data together, and there were 857 biopsy-proven amyloid patients. And we found out that sensitivity and specificity was excellent, especially if we had ruled out AL amyloidosis in these patients. That time we came out with this algorithm for diagnosis of the patients. So first, if you have any symptoms or clinical features or clinical clues of the cardiac amyloidosis or imaging clues of cardiac amyloidosis, you do a PYP scan or DPD scan or HMDB scan, either one of those, and also do the serum and urine immunofixation and free light chain ratios. And then if both are negative, you do not have cardiac amyloidosis. If your PYP scan is positive with grade 2 or 3, and your urine and serum are negative, then you have TTR amyloidosis. If you have a grade 1, or if you have your urine and serum positive for immunofixation and or free light chain assay ratio is abnormal, in those patients, you would consider getting a biopsy. I'm going to skip that. So I'm just going to quickly touch base on treatment. So treatment is really divided into three different areas. One is, which we call reducing the production of TTR, which is synthesis suppression. So in the old days, we used to do liver transplant on these patients, but now we have gene silencers, which are patisiran, vutrisiran, and inotersen, which are used to reduce the synthesis by 80% of the TTR synthesis. And now in phase 2 trials is gene editing with CRISPR technology, and also currently the medications which are available for neuropathy, TTR neuropathy, are vutrisiran, inotersen, and patisiran. And patisiran, the results for cardiomyopathy were presented a few months back, and now next month we're going to hear from FDA if they approve it for cardiomyopathy. Then we'll have 2 approved drugs, which would be Vyndamax and or tafamidis and patisiran. Now, eplontersen, we will get the results of their trial in early 2025. So every year we are going to get 1 or 2 new drugs to treat this disease. Then the next step, which we come down to, is stabilizers, which are Vyndamax, which is tafamidis, diflunisal, which is non-selective, which is an NSAID, and it's off-label use, or acoramidis. Acoramidis just presented their phase 3 trials, which showed reduction in cardiovascular mortality and also reduction in hospitalization. And they will hopefully be submitting to FDA for NDA. Then we will have another stabilizer, hopefully next year, in market. So we'll have some, tafamidis will have some competition, which would be good. And then the next one is, which we call elimination of deposits. And those, I use off-label doxycycline 2 on my patients. And the ones who are not responding, whose disease is progressing with the Vyndamax, or some of my patients are on are on stabilizer and silencers. And then there are a lot of new ones which are coming out. And also there's ECGC in green tea, which has been shown in some earlier trials is beneficial in these patients. The other thing is important in treatment is how you treat their heart failure. These patients cannot tolerate ARNI, ACE, ARB, and also beta blocker worsen their symptoms because they are relying on, their stroke volume is small, and they are relying on the heart rate to increase their cardiac output. So if you beta block them a lot, that their symptoms get worse. So I put my patients who can't tolerate it on spironolactone, and I also put them on SGLT2 inhibitors. Avoid loop and thiazide diuretic agents in these patients usually. Only if they need it for volume overload, I would do that, but they're usually intravascularly volume depleted. Then heart transplant and select advanced patients, but usually the other therapies, LVAD and all those don't work for these patients because they have small LVs and RVs are involved. They're also in then palliative care in some of these patients who are not doing well. For arrhythmias, remember, like we discussed, for AFib patients, do not cardiovert them, even if they have been on anticoagulation. Need to do a TE because they have, even on anticoagulation, they have a thrombus sitting in their left atrial appendage. I think the most important thing is, the price of these medications. Just if we look at tafamidis, just the price of the medication is $225,000 a year. If we look at patisiran, the price without the patisiran, they have to come every 3 weeks for an infusion. I'm not taking into account for the infusion center charges and all that. It's about $400,000 each year. Then vutrisiran, on which some of my patients are on vutrisiran, each sub-Q injection costs $125,000, and they have to get 4 injections in a year. So I think that's where the biggest problem is. Just going to skip that because of the time, and I'll just wait for some questions.
Dr. Bakari, as always, thank you very much for that very comprehensive, very thorough talk. I just have a few questions about management of amyloidosis. How do you follow, or how do you monitor their response to treatment? Do you do serial imaging, or do you just follow them clinically? So that's my first question. My second question is, what is the role of biopsy in diagnosing patients with amyloidosis?
Yeah, both are excellent questions, Ken. So the first one is what I do is I look at NT-proBNP, I look at troponin, I look at prealbumin, I look at EGFR, and I look at modified BMI on these patients. All these help me to see if they are responding to treatment or if their disease is getting worse. Role of imaging. So the first paper which I had published was in 2015, in which we did serial imaging with PYP scan on patients at baseline and then at 15 months post-treatment. We did not find any difference. But then there have been few papers, I would say about 5 papers in total, looking at imaging to see if there is any benefit of imaging and looking at progression or regression of disease. And like Apollo B trial. Apollo B had imaging as one of their, in a sub-study. And they showed some benefit in there. Then Cheng and group did with tafamidis and looked at some of the patients with tafamidis, found some benefit there. But these are small cohort studies. And then there were a couple of case reports which came out that did not find any difference compared to wall thickness or compared to your NT-proBNP, other biomarkers. The other thing which imaging helps is looking at LV wall thickness also. If the thickness increases by 2 millimeters, that gives me a clue that it's getting worse. The thing which really helps in imaging, Ken, is ECV. So Julian Gilmore from National Amyloid Center from UK has shown excellent results in following these patients with ECV and looking at progression or regression of the disease by ECV. So I think out of imaging, ECV is really helping in that. So your second question was about biopsies. That's a very important question. So if I have a higher clinical suspicion in patients, even if my PYP scan is negative, even if MRI is not that diagnostic, I would still send the patient for biopsy. And as I don't know if Mike is online or not, Mike Wong, and also Chaudhary, I've sent a lot of patients who have been completely negative with everything else and came back positive with biopsies. So it's important, if your clinical suspicion is high, send the patients for biopsy. And the other thing which is important is with biopsy, always request them to send your biopsies for spectrometry. We had a couple of patients who they did it over here, they did immunohistochemistry and said patient does not have AL, and we sent it to Mayo Clinic, it came back positive for AL amyloidosis. So important that we follow up with spectrometry because that's the gold standard.
Dr. Gaywell?
Hi, Dr. Bakari, great talk. I had a couple questions as well regarding the management of amyloid. We talked about, or in your presentation, you mentioned conduction abnormalities. Is there a way to risk stratify who will go on to perhaps need, pacemakers, or who would go on to develop a high-grade AV block in the future?
Right. So these patients, as you know, there's so much deposition in the atria, right? So, and what I have noticed in these patients, when I send them for pacemaker, I always request the person who's putting in his put up by IV pacing. These patients usually don't do that well with this RV pacing, and their EF usually goes down, they get more symptomatic. And so if you do by IV pacing in these patients, they do well, they do better. But so which patients you're going to put pacer in is it's the same indication which you have for your regular patients. If they're going into AV blocks, having problems, you're going to put. But I always request the person who's putting it in to put in by IV pacing.
Yeah. And another question I had is, in the world of, in the transplant world, when we consider these patients for advanced therapies, most, as you mentioned, LVADs are usually not an option. We always worry about the degree of involvement with the autonomic dysfunction that's present. Is there a way, or has there ever been like a objective criteria that has been formulated for patients with like wild type or any type of amyloid?
Right. So that's an excellent question. If you look at it, that it says that if your modified BMI is less than 600, if you have autonomic neuropathy and your blood pressure is low, or you're on midodrine or Florinef and you can't get off of that, then you are not a candidate for transplant.
Yeah.
But I'll give you one quick example. I had a patient who I've been following now for over 10 years, 40-some-year-old, now he's 50-some years old. His wife brought him from Ecuador and said that, my husband's family is cursed because 7 generations, she had the whole genetic thing with her, big file disease. None of the male members live for over 55 years of age. And the patient had severe autonomic neuropathy and also had peripheral neuropathy, and was debilitating, basically. And so we looked at it, we did his genetic testing. He had a mutation, rare mutation. We, in fact, also published that case report. It was the 4th case report of that mutation. Now, at that time, because he was young, we decided to do a transplant on him. And what we did was we did a heart and liver transplant. And at that time, there was a cirrhotic patient, 78 years old. He was very sick in the hospital. And we gave this guy's liver to him. It's a domino transplant. So we gave him that. Now, this guy, for the last 10 years, he's still following. He still comes here. He's doing well. He's doing well with the transplant. Really, his neuropathy has also improved. But the other guy who got his liver, after a year, came back with severe neuropathy and died a year later. So because this was a strange mutation, a rare mutation, which was very aggressive. So to answer your question, autonomic neuropathy patients, usually, if you go by guidelines, if they are severe autonomic neuropathy, or if they have they're on midodrine, they can't come off of that, they are not eligible for transplant.
Thank you.
Dr. Bukhari, I have one more question. As you know, the AF prevalence in patients with amyloidosis is quite high. Do we even bother with cardioversion or ablation if the recurrence is also high?
And that's an excellent question again. So 70% of the patients have atrial fibrillation with ATTR, cardiac amyloidosis. If the patient is an early disease, I would send them for cardioversion and ablation. In late disease, none of those work. You send them for cardioversion, they go back into AFib. You send them for the ablation, doesn't work. So in early disease, I would do it. In advanced disease, later stage of disease, it's not going to work.
Hi, Dr. Bukhari. This is Ashok. Can you hear me?
Yeah, hi.
Yes, hi. Sorry, I was in the lab. I arrived late, but you do mention that there is a significant overlap of amyloid patients in a lot of severe symptomatic AS patients that we see. The question that I have is, since it is a huge population of patients, like how do we target for screening for these patients? Do we find those patients who are younger, or do we find those patients who don't do well despite getting a valve replacement? Or do we, is there any kind of other markers other than LVS? Because everyone will have LVS with severe AS. Like how do you, as a program who sees like more than 400, 500 patients a year for just valve replacement or even bigger other programs, how do we like channel these patients so that they also benefit and we're not like over testing them?
No, that's an excellent question, Ashok. So we, in fact, when we started doing this at Columbia, that was the main question which everyone asked, that we were doing such a large volume. How can we screen? How can we screen everyone? So what we did was we came up with a score, which I presented a slide here. Probably you were not there. So how to select which patient you need to screen for in TAVR. So that score system helps us to really look for patients who have a high pretest probability of having TTR in TAVR patients. And we did the score so that the pretest probability for those patients would be greater than 25%. So that really narrowed down the patients who were going for TAVR who should be screened. And again, if you screen without that score, 22% of the males which you're doing TAVR on will have TTR cardiac amyloidosis. And so that way you can diagnose these patients and treat them and basically help them for living longer and better quality of life. So I think what I can do is, Ashok, I'll send you that score also. I'll send you that slide. You can
Sure.
take a look at it and consider screening your patients.
Oh, excellent. We'll collaborate. Thank you so much.
Hey, can you hear me?
Yes.
Hey, I think you had mentioned, this is Brian, by the way. I think you had mentioned that both patients with atrial fibrillation as well as patients without known atrial fibrillation with amyloidosis are at high risk of LA thrombi. Has there ever been any, any data or any studies looking at anticoagulating or screening for patients who are not known to have atrial fibrillation with amyloid?
Right. So that's an excellent question. There's a right now trial going on, multi-center trial looking at that, Brian. So what I do for my patients is that I would, if I can, most of the places do that, will do a quick CT scan, which is with the late imaging. And in that, you can pick up the atrial appendage thrombus. If the thrombus is there, even if they are in sinus rhythm, you put them on anticoagulation. Because there's a very high rate of stroke in these patients because of this thrombus, which is sitting there. But the other biggest problem is that there's a large percentage of these patients, even on anticoagulation, still have a thrombus in there. So that's why we have to be really careful. And that's why the recommendations are that in these patients, you do not go with CHA2DS2-VASc score. Any one of these patients, if has any episode of AFib, put them on anticoagulation.
Thank you.
Any other questions from the group? Again, Dr. Bokhari, thank you for that very comprehensive and excellent presentation. Thank you.
Thank you, guys. Thank you.